We hope that you are all well. My name is Charles Snyder, and on behalf of my co-chair, Dr. Craig Littlehigh, and the entire Professional Development Committee, we would like to welcome you to APSA's second annual Tech Talks, or Top Educational Content Talks. As always, we would like to thank APSA and the Journal of Pediatric Surgery for their very generous support of these talks. Tech presentations are patterned, of course, after the popular internet TED Talks. The intent was for each speaker to condense their knowledge that they wish to present down to 15 minutes or less with minimal slides in order to maximize interest and increase the retention of the listener. A bit of background about the PDC. Our primary charge is to collect, revise, and prioritize knowledge gaps and practice gaps that we identify in our profession. The input for these knowledge and practice gaps is from a variety of sources, but by far the most important one is from all the APSA committees, and we would like to thank them for their contributions and their hard work. Once we identify these knowledge gaps, they need to be sent out, and that's done through a variety of mechanisms, through the expert questions and discussions, through the Not a Textbook, both available at pediatricsurgerylibrary.com, through Todd Ponsky's Global Cast reviews, through the monthly articles of interest, again coming from the APSA committees, or by way of the Sunday-spaced learning courses. These tech presentations, however, are the primary venue for our top 4 identified educational or knowledge gaps for the year. Our only ask of you, the viewer, is to identify and submit any knowledge or practice gaps that you have to us. This can be done in a variety of ways. You can simply use the chat box and put in knowledge gap or KG, or you can email them to think@eapsa.org. We need and we value your input, and we depend on the wisdom of our crowd. Following talk by Dr. Jason Frischer from Cincinnati Children's Hospital updates us on the status of biologics in the treatment of inflammatory bowel disease. He is joined at the end of his talk by 2 discussants, Dr. Aaron Lipscar and Dr. Kevin Mullen. I think that you'll find this talk both enjoyable and interesting.
I would like to thank the APSA Executive Committee, David Powell, Casey Calkins, and Todd Ponsky for doing what many of us thought would be impossible and putting on a great virtual meeting and helping us all share and disseminate our learnings in pediatric surgery. I absolutely love that we are able to share our meeting with people all over the world. And I would like to have a conversation with you about how the anti-TNF and other related biologic therapies influence our surgical care of the inflammatory bowel disease patient. What is a biologic? A biologic is a compound derived from living cells. The first biologic was FDA approved in 1982, and that was Humulin. And if you recall, that is a recombinant form of insulin. The biologics used to treat inflammatory bowel disease are typically monoclonal antibodies. Now in 2020, we have numerous biologics and many more in multiple clinical trials. So how do these drugs work? Let's look at this cartoon as it demonstrates how they work at the level of the gut epithelium and are antagonistic to the cytokines IL-12 and/or 23 TNF-alphas, or they interfere with cell adhesions. A simpler diagram is displayed breaking down the biologics into cytokine blockers or integrin blockers. The integrin blockers, such as vedolizumab, the cytokine blockers either work on the interleukins, primarily IL-12 or 23, or the anti-TNF agents like infliximab and adalimumab. Very new to the scene are a term called biosimilars. This is the generic version of biologics. When we talk about biologics, we must discuss the risks. With all biologics, immunogenicity or host immune response to the therapeutic may occur. One could develop allergies to the medication and/or resistance. One must also consider that these are quite potent immunomodulating agents, and therefore the infection risk is elevated, including opportunistic infections such as tuberculosis. Finally, we must discuss the elephant in the room, which is the black box warning of T-cell lymphoma associated with teenage boys particularly treated with infliximab plus azathioprins. The risk is somewhere in the order of 4 to 6 per 10,000. And that is what is quoted to many of the patients. That being said, we've discussed the risk, particularly with all patients being treated with anti-TNF agents, as well as all biologics, that there are potential risks. When talking biologics and how they are used, the term pyramid should be part of the conversation. Previously, many gastroenterologists would treat IBD patients from the base of the pyramid with milder agents up to the apex where more potent agents and surgery reside. Recently, the pendulum has swung to a more aggressive style of treatment, starting at the apex, especially for high-risk patients and those with moderate to high severity of disease. So let's go into some of the questions that we have about biologics. First, have biologics changed the rates of surgery in patients with luminal Crohn's disease? So those are patients with stenosis or fistulizing disease. Have we been operating less? Well, the 1, 5, and 10-year rates of surgery for Crohn's disease patients are quoted at approximately 14, 28, and 39%. And this was studied in the 90s, and it has not changed much during the biologic era. Next question. Have biologics changed the recurrence rate following resection in patients with luminal Crohn's disease? This is a little bit more interesting. When you study it endoscopically, the recurrence has dramatically improved. This will, I believe, have long-term effects. But currently, there are mixed results from clinical endpoints, meaning need for reoperation, strictures, etc., have not been shown to be improved in the biological era to this point. So, have biologics changed the rate of recurrent surgery in patients with luminal Crohn's disease? The 5 and 10-year reoperative rates are close to 25 and 35%. And these numbers are greatly decreased from the 70s and 80s when these numbers were as high as 60, 70, or 80%. But in the 90s and early 2000s, these numbers decreased once we started treating postoperative patients, and they have not changed during the biological era. So I think with the endoscopic changes that we are seeing, we may in the long term see a change, but currently no data really shows that there's a change. So I give this a maybe for now because I'm hoping for the best in the future. Have biologics reduced the rate of colectomy in patients with ulcerative colitis? Well, we know between 10 and 30% of patients with ulcerative colitis ultimately require a colectomy. But with biologics in the biologic era, the results are mixed, and a number of trials looking at this question have not borne out to show that biologics change that outcome. What we do know for sure is that biologics can certainly delay colectomy in many patients, in those with moderate to severe disease. So I give that also a maybe. Here's the questions the surgeons really want to know. Have biologics changed perioperative complications? We know that patients with inflammatory bowel disease, in general, have a higher rate of perioperative complications. Implicated risk factors include nutritional status, steroid use, and preoperative abscess. The effect of biologic therapy on perioperative complications is extremely controversial, and that is why I gave this a big fat maybe. Some meta-analyses have determined that there is an increased infectious risk with the biologics, but recently at DDW, a presentation was given on the Puccini study. It is a 17-site, 955-patient prospective study that concluded the preoperative use of anti-TNF drugs was not an independent risk factor for post-op infections. I would be remiss not to mention a pediatric paper out of Boston 2 years ago that reported an increased rate of stoma dehiscence with patients recently treated with vedolizumab. I bring that paper up to note that all the papers that I'm talking about, most of the data that we have is pertaining to adult literature, and we have to extrapolate from that. When is it safe to restart a biologic after surgery? Well, most trials demonstrate that it is safe to restart biologics 4 weeks after the surgery. I know we have restarted therapy as early as 2 weeks in patients with particularly virulent disease. We have not seen any postoperative complications. Let's change topics for a moment and go to the other end and discuss perianal disease. I present the case of a 13-year-old male who came to our emergency department. What is your next step? MRI, MRE, antibiotics, surgery, biologic therapy? Let's discuss, does this patient even have Crohn's disease? We performed a study here at Cincinnati Children's looking at over 1,000 patients presenting to our emergency department with perianal symptoms. We looked at age, gender, and perianal presenting symptom to see if we can predict a new diagnosis of Crohn's disease. Using multivariate analysis, we found 3 findings. 1, patients greater than 10 years of age, males, and patients presenting with a fistula had a much higher propensity of having a new diagnosis of Crohn's disease. So when this patient came to our emergency room and followed up in my office a few days later, this is what I found: a giant crater that was unable to heal. And I can tell you this patient 2 years later, after a colostomy closure, finally was able to have healing of his perianal disease. So I caution everyone in going down to the emergency room and just incising and draining perianal abscesses in these male patients, particularly over the age of 10, and maybe also demonstrating a fistula. Treatment of perianal Crohn's disease. We all are aware that there's medical and surgical therapy for perianal Crohn's disease. I would like to focus on the use of biologics. Multiple studies have shown superior treatment with a combination of infliximab and ceton placement. The combination improves fistula healing, recurrence rate, and interval compared to medical therapy alone. What is interesting is that even with this data and multiple studies, a study out of Spain demonstrated that only slightly more than half of the patients received an anti-TNF agent, and a study out of the Netherlands showed that only 40% of those treated received a combination of medical and surgical treatment. So I think there's certainly room for improvement. In conclusion, I'd like to state that biologics have not changed the surgical need in inflammatory bowel disease. Preoperative use of biologics may have increased risk, but many studies refute those early findings. You may safely restart biologics 4 weeks following surgery, if not sooner. And biologics plus ceton placement is best for treating perianal Crohn's disease. And now I'd like to invite Dr. Kevin Mullen from Pittsburgh and Dr. Aaron Lipscar from Cohen Children's on Long Island to further discuss perianal and abdominal Crohn's disease and the use of biologics.
To start, Jason, maybe we should go back to that case you presented. Are you suggesting that that patient should always head straight to the operating room for an incision and drainage and ceton placement? Or is there a role for imaging, even in the acute setting, to look for fistulae or small bowel disease?
I think that's a great question. How to work up the patient in the emergency room with perianal disease. And it's a hard question to answer because if you start looking at use and utilization, it could get very dicey. But I would say and suggest in patients in the teenage years, in their first showing of perianal disease, and obviously if they have a family history, but even not, if time allows, an MRI to further investigate the depth of infection is certainly warranted. I originally did this study because I thought every patient that came to the emergency room had Crohn's disease, that had perianal disease. Boy, was I off. It's not nearly that high, and in the patients less than 10, the numbers are very small. But the patients older than age of 10, we found in the males with fistula and greater than 10 years of age, it was over 35%. That was their initial diagnosis of Crohn's disease. The other thing I found is that if I IND these wounds and it does not heal the way I suspect, that is Crohn's disease. Every single time when it doesn't heal the way you suspect with, local wound care in a short period of time, they all have been diagnosed with Crohn's disease.
I guess I would transition to ask both of you the question of what your practices are in terms of when to remove a ceton after biologics are started for perianal disease.
We all kind of struggle with that. The tradition here has always been to remove the ceton when the patient is begging you to remove a ceton. For some patients, we know over time they certainly can become symptomatic. And, a lot of people will say leave the ceton until it falls out. Well, that certainly can be a long time. I truly do let the clinical course guide things to some extent. I like to leave them in for a few months at least. Patient isn't bothered by them. I'll let it, I'll certainly take into account whether it's draining, whether there's any evidence of inflammation, whether the inflammatory markers are still elevated. You want to get to that point where you truly feel that disease is controlled. But certainly patients will want them out, and then I'll entertain it. And we just have a discussion about the risks and benefits. Certainly there's always risk when we're moving a ceton. That's something new is going to be awesome, and you're going to be back in the operating room.
So let's change gears a little bit and let me throw to you guys the other half of the conversation. What do you do preoperatively and postoperatively using biologics? When do you stop it? Do you stop it at a certain time? And when do you restart?
Great question, and a very complicated question, obviously, because there's a spectrum of diseases and indications for the biologics. I think the first piece are the children with ulcerative colitis that are on biologics. And those patients, my understanding of the literature, although I know that there are opposite papers, is that there was a higher leak rate from an ileal pouch anal anastomosis on biologics. So in our institution for over 10 years now, we've put a moratorium on that operation for children on biologics, and they're all getting subtotal colectomies and endoleostomies without any delay time of holding the biologics prior to that operation. And we haven't seen any increased complications. For the Crohn's case, my bias has always leaned on that maybe it doesn't affect complications. And I have not required biologics to be stopped for any long period of time. In fact, our gastroenterologists are sometimes more nervous about it than I am.
Yeah, I would echo a lot of that. The way I would kind of summarize the data is that, there may be an increased risk of infectious complications on biologics, but I would say the studies would suggest that if that risk is there, it's mild to moderate. For the most part, we similarly in the setting of ulcerative colitis have moved towards, as most centers have, moved towards an initial upfront total abdominal colectomy. I think that has to do with biologic therapy. It also has to do with nutritional status and just simply inflammation, ongoing inflammation. And I will do that operation without stopping biologics. In the setting of Crohn's disease, I would say that if possible, I like to stop biologics at least 2 weeks ahead of time, if not 4. I think it's what the disease will give you. Since